The intraoperative cardiac monitoring, cardiac output monitoring rather, it's become quite in vogue, and I think it is important for us to keep a very close eye on this because it's very promising. But there are challenges when we use this monitor, and it depends on the context, what you want me to talk about. First of all, I'm not sponsored by any industry, and I'm not against industry, so this is as objective I can be in talking about this topic. So the objectives here is that we will review the reasons for intraoperative cardiac output monitoring. So it's not cheap, so it doesn't make sense for us to just slap on a monitor on everybody. So we have to understand why we're doing this, and then we have to review the existing monitors. Now, in 20 minutes, it's very hard for me to give you a very detailed analysis of this, but I will give you a broad overview. And then we'll understand what the variability of cardiac output determinants. So cardiac output is not a single indicator that we can very simply monitor and tell us everything. It is something as a symptom as opposed to the cause. So we have to understand what the cardiac output means. Oh, sorry. Can you hear me now? I apologize. And I will give the sort of the current thinking about the use of cardiac output monitoring. So the reason for cardiac output monitoring is it depends on why you want to use it. In the case of moderate to high-risk cardiac patients, I really don't see any reason to ignore transthoracic echo or transesophageal echo, or even in the old days, and currently still a lot of people believe in the PA catheter. It really still comes down to if you have a high enough risk patient, those modalities still should come back in for you to think very carefully about. In the context of ERAS, which is enhanced recovery after surgery, which has been very much talked about, in the last 10, maybe even 15 years, really the cardiac output is part of the dialogue that we have about fluid management under ERAS. But I want to give the context. It's always important for us to understand why we're doing certain things. ERAS is not about fluid management only. ERAS is about a whole bundle, a whole package of what we have to do. ERAS is about what we need to do, we meaning surgery, anesthesia, as well as potentially internists or other specialties before admission. And then the day before surgery, the day of surgery, and the post-op care. But on the day of surgery, intraoperative fluid management is a key component of ERAS. And this is from one study outlining what the bundle is about in ERAS in 2006. And the same thing about ERAS in other journals, and you can go and look it up. But they emphasize, again, goal-directed fluid therapy and alternative analgesic modalities. Those are key components, or two of the key components, I should say, that affects enhanced recovery. So it's not just the fluid. So we should not delude ourselves to think that if we manage the fluid perfectly, then the patient is going to go home early. Now, the NICE guidelines, which is what is used in the UK, recommended the adoption of CardioQ in 2011. It stirred up a lot of controversies in the UK. Nevertheless, from their perspective, it reduced post-op complications. There was evidence for that. It reduced the use of CVP lines, and it reduced the hospital stay. So what's there not to like? That's why they went with the CardioQ. So what are the monitors that we are talking about? So once you have something like the organizations such as the NICE, Coming up with a set of guidelines like that, it really sort of stimulates the whole discussion. Okay, we need to now use the monitors. So what monitors do we have? Well, we have pulse contour, that is the flow track, or using the arterial line, and then from there you can calculate the pulse contour of stroke volume variability. Now there's also photoplethysmography. I always have trouble saying that word, but I said that one time nice, okay. Esophageal Doppler, and that's the cardio Q, and as you probably know, that's a Doppler probe put in the esophagus, because it's just a Doppler. It's a very thin probe compared to the transesophageal echo probe, although the TEE probe nowadays is becoming so much smaller as well. So the Doppler beam, the cardio Q, you line up essentially the aorta with the Doppler beam, and you try to measure the cardiac output. There's also bioimpedance, and that is measuring the amount of fluid in the thorax during each cardiac cycle, and the impedance changes. So impedance is a very interesting physics phenomenon, and it's used in many circumstances. So even in volcanoes, people have used impedance to measure whether the volcano and the magma flow increasing, whether it's going to explode. So impedance is a very real and validated concept in many of the physics experiments. And nevertheless, in humans, it's not been that accurate. So then we go on to bioreactance. That's the next level. So I'll touch on that in a sec. The pulse contour is area under the curve of arterial waveform. So you have the arterial waveform, and any of you who still remember your calculus or differential equations, it is integrating the area under the curve for the waveform, and that gives you the pulse contour. And then they can use mathematics to transform the pressure waveform to flow waveform. It depends on three variables. It depends on the aortic impedance, it depends on the arterial compliance, and it depends on the systemic vascular resistance. And you can think of, if you think carefully, situations where one or many of those variables change. Therein lies the problem. All of these monitors have the same advantage. It's convenient, it's easy to put in, or relatively easy to put in, relatively non-invasive. However, it could produce errors when you have changes in peripheral vascular resistance. That's one of the biggest problems. So any one of you who's done cardiac or doing cardiac would know what I'm talking about. You may have the radial arc line in. When you're coming off pump, many of the times you will find that your radial arterial pressure is nothing like your aortic root pressure. That difference is due to systemic vascular resistance. It's been studied. People have used nitroglycerin to try and reverse that. Whatever the reason is, when you don't know what the cause is, and you're in non-cardiac surgery, you don't have the aortic root line, now you're guessing as to what you're seeing, is that real or not. The esophageal Doppler, we tried it as well. I have to admit, when we first tried it, we tried it in a thoracic case. That was kind of foolish, because as soon as the surgeon changed the position of the patient in thoracotomy, all our Doppler measurements were right off, because the position of the aorta to the Doppler beam and the thorax completely changed. But even in laparoscopic robotic surgery, going into the steep Trendelenburg, my gosh, where is the true Doppler beam angle we should be? So the problem is when we change position. And we also have situations where aortic diameter changes during surgery, and that's partly due to the compliance in the aorta changes. So the Doppler beam is different from TEE in the sense that you don't have a picture to tell you that you are lined up properly. You just have to rely on the Doppler, and it produces some errors. Bioimpedance, as I sort of refer a little bit, it is a physics, a mathematical measurement of the physics of fluid in a certain area, and in this case it's in the thorax, but we know that in the presence of pulmonary edema or changes in peripheral vascular resistance, the fluid in the thorax may not be actually blood flow, and that's where the discrepancy came in. And in fact, bioimpedance never really caught on, because very early on people already noticed that it just was not that accurate. We also then went to the next level, bioreactance and electrical velocimetry. Velocimetry is the second derivative using bioimpedance. And again, some people say it's accurate, some people say it's not accurate, but I would refer you to Critchley's article in the Anesthesia and Analgesia, and basically they found that when you have extreme height, and in female, as well as in situations where you have high cardiac output or low cardiac output, it's not accurate. The bioreactance is looking at the phase shift in the voltage of bioimpedance as it changes, and again, same sort of errors that occur. However, more and more people are now looking at trending. Is it a good thing to look at the trend of these monitors, not the absolute number, but the trend? If the trend starts to show a change, maybe that's when you should go by the trend, and if it's concerning, maybe you should go to the next level of TEE or some other means of monitoring more precisely what is going on. And all of you know this. I just very briefly remind you, when we talk about volume, we're only talking about the preload. It's the Frank-Starling curve. You give volume when it's low, and then you start to see a fluid response when you move the volume up the Frank-Starling curve. Well, except the Frank-Starling curve changes when there's increased contractility due to sympathetic stimulation, so the curve shifts, not along the preload curve, but it shifts to a different family of curves. And then on top of that, guess what? The systemic vascular resistance changes also how your Frank-Starling curve responds. We all know that. This is all from our basic physiology, early university or medical school. And this is kind of the graph that you would expect to see. So when you're just monitoring the cardiac output without knowing the context of where this is coming from, you may think it's a very simple little indicator that you can just rely on. But it really means that you have to decipher all of these little things that change your Frank-Starling curve. On top of that, we all know that determinants of cardiac output are multiple factors. Heart rate, we can tell. We can tell from the ECG how the heart rate is changing. The preload, we can use maybe the Frank-Starling curve. The afterload, well, we don't always know. And we know that if the patient bleeds and you're hypovolemic, we start to see the pulse contour change. That's how the stroke volume variability started to come in as an indicator. Contractility, we have myocardial ischemia, we have systolic dysfunction or failure, we have diastolic dysfunction or failure. None of that is measured. When you see a drop in cardiac output, you have to try and decipher what actually is causing that. We also have pulmonary hypertension, we have valvular diseases. So a number of things, variables in there that we have to decipher. So I will give you a case, a 46-year-old man for obstructive sleep apnea and hypertension for septoplasty. Not big deal. Episodic shortness of breath with moderate exercise, well, I can vouch for that every day if I try to run up the stairs. No previous general anesthetic, no medication allergies, and the only thing was the atenolol for the hypertension. examination, unremarkable. BMI was 43. After induction, BP dropped to 65/30, and BP continued to drop despite ephedrine in increments. And the anesthesiologist decided to use epinephrine, 50 mics, heart rate 102, no BP improvement, TEE then was done. This was a case report in the Canadian Journal of Anaesthesia. I've given you the reference. You can actually look at it yourself. And can I have video number 1? So I'm going to shout. If you look very carefully, there's a lump. In the LV septum, there's a lump right there. And can I have video number 2? So this is zoomed in on the echo, and you can see the lump. And if you are quick with your echo skills, you even see a systolic anterior motion of the mitral valve. This patient has an undiagnosed HOCM. And by giving ephedrine, I guess, first of all, the patient was induced, became hypovolemic, given ephedrine, increased contractility, the HOCM got worse, then the patient was given epinephrine, even worse. We wouldn't have known what was going on. Fortunately, it wasn't my case, believe me. But the anesthesiology was really sweating because the patient was crashing. And we couldn't diagnose what was going on until the TG was put in. Completely undiagnosed pre-op. Thank you. I'll go back to the slides. You can stop the video. Thank you. So really what we're talking about is in perioperative fluid management, there are a lot of principles starting to come out, and they are really very good principles. When I was a resident, even when I was a staff consultant, oliguria intraoperatively was something you treat. You really try to load the volume. Well, now it's not in favor anymore. When we see stroke volume variation about 13% right after induction, well, it may not be hypovolemia, and I just showed you, in fact, in the case, it was HOCM. I think I pressed the wrong button or something happened. That's okay. So now we have a more balanced approach, and it is important to remember that NICE guidelines actually did have some qualifications. It said that in moderate to high-risk patients, when you are in fact looking at putting in a central line, that's when you should be using continuous cardiac output. It does not say that every patient you should be monitoring cardiac output. And this was a nice little article by Timothy Miller. He also put an article in Perioperative Medicine. Both of these articles, if you are looking at fluid management, I think it gives a reasonable summation of where our current state of understanding is. And essentially, in the left lower corner, it says low-risk patient. You just use your clinical management. And a lot of people would say that this is the zero balance fluid management situation, meaning you don't use a formula and say that this patient must get so much volume for third space loss. You see what is lost, you see what is sucked out, you replace that. That's it. That's your zero fluid balance. And then if you have higher risk in terms of surgery or higher risk in terms of the patient, then you start to use the goal-directed fluid therapy. And in that case, the goal-directed fluid therapy is not to drive the oxygen delivery content, which is the goal-directed therapy, another term that was used in ICU or that is used in ICU. This goal-directed fluid therapy is just to see how much of a response in the presence of hypotension can you get with fluid loading, and you can measure that potentially clinically or using cardiac output monitors such as the stroke volume variability, which is the pulse contour monitor. And then in very high risk, both in terms of surgery in the patient, then you would definitely use ghost-directed therapy, and I would actually add to that, that's where you probably should be looking at a TEE or transthoracic echo if it's under regional anesthesia. So in essence, we are talking about a risk-stratified approach to fluid management. One size does not fit all, and guess what? It comes back to the person who is managing the anesthetic has to think through what is going on and watch the suction bottle, watch the drapes, watch the peritoneal cavity if it's an abdominal surgery, because if you have a patient with ascites, that's a different management plan than a patient with a laparoscopic MIS surgery for the same procedure.
Time.
This is my summation. For every complex problem, there's always a simple solution that is wrong. If you're looking for a simple cardiac output to tell you everything, we don't have one. Thank you.
Thank you very much.